So on to the glomerulonephritis. So glomerulonephritis is simply what it says. It's a disease of the glomerulus. And the more prominent features in glomerulonephritis are going to be hematuria, red cells in the urine, or it can be edema if we actually have nephrotic syndrome. This is in contrast to the tubulointerstitial diseases where we actually see uremia as a prominent symptom. So the reason for this is because things like edema and having brown urine are going to cause patients to come in right away. Whereas if you're having azotemia, you're not going to know that until it progresses into the symptoms that we see in uremia. So patients with glomerulonephritis just tend to come in faster. It really has nothing to do with the severity of the disease. So in glomerulonephritis, we tend to have a moderately low urine sodium and low fractional excretion of sodium. And the reason is because where are all the afferent arterioles? They're all sitting in that glomerulus apparatus, in our filtrating apparatus. And so when we have a disease of the glomerulus and there's inflammation there, it's going to cause the glomerulus to perceive less blood getting to the kidney itself. And that's just simply because there's congestion. And so what happens then is you're going to have pre-renal-like features, and so your urine sodium, fractional excretion of sodium will be decreased somewhat. Key labs on your urinalysis, you're going to see, and this is where you want to focus really when you diagnose glomerulonephritis. When you see red cells in the urine, when you see protein in the urine, that's glomerulonephritis until proven otherwise. That's not tubular disease. That's not pre-renal or post-renal. Red cells in the urine, protein in the urine, and red casts in the sediment, that's glomerulonephritis. And you also will see a low sodium, but focus on the sediment and on the red cells and the protein. On complete metabolic profile, a lot of times you're going to see azotemia, but it's going to be subclinical. You're not going to have symptoms from that azotemia. You're not going to have uremia. You're just going to have azotemia. So maybe a mildly elevated creatinine, mildly elevated BUN. It's important to get a CBC on all these patients because we want to see if this is a chronic process going on. We want to see if they have anemia. We want to see if they have how their platelets are. We always want to get a 24-hour urine protein, and that's simply because in order to diagnose nephrotic syndrome, which we're going to talk about, we have to have a 24-hour urine protein. It's not enough just to have the dipstick. And then renal biopsy for glomerulonephritis tends to be the conclusive diagnosis. So we need to think of all the syndromes that cause glomerulonephritis as distinct processes, but they all lead to a similar problem, which is what we have here in our urinalysis, which is red blood cells, red casts, and proteinuria. So what's the difference between nephritic syndrome or nephrotic syndrome? Don't think of it as some diseases cause nephritic syndrome and some diseases cause nephrotic syndrome. Nephritic syndrome is all of these diseases we're going to talk about. It's red cells in the urine. Nephrotic syndrome is when we have enough protein in the urine to where it's equaling or exceeding 3.5 grams per day, and we have symptoms. So nephritic syndrome is red cells in the urine. Nephrotic syndrome is having more than 3.5 grams of protein spilling out in the urine per day. So let's just briefly compare tubulointerstitial disease and glomerulonephritis. So as we mentioned, the urine sodium is going to be low compared to in tubulointerstitial disease where we can't reabsorb the urine sodium, so it's going to be high in tubulointerstitial disease. But don't look at the sodium or osmolality of the urine as a distinguishing feature. What the distinguishing feature is going to be is the debris. And it's going to be the protein and the red blood cells in the urine. So these three things are going to be what you want to consider as differentiating tubulointerstitial from glomerulonephritis. You're not going to see red cells in the urine. You're not going to see protein in the urine in tubulointerstitial disease. What you are going to see in tubulointerstitial disease is muddy brown casts, which are sloughing off tubular cells, and eosinophils, which is if we have interstitial inflammation. In glomerulonephritis, which we're talking about now, you're going to see red blood cell casts. You're going to see red blood cells in the urine, and oftentimes, to one degree or another, you're going to see protein in the urine. The causes of glomerulonephritis tend to be autoimmune or congenital, and the diagnosis is going to be urine protein, renal biopsy, and sometimes we're going to need to get complement levels. The treatment for glomerulonephritis is going to be steroids and sometimes immunomodulators, unlike in tubulointerstitial disease where the treatment tends to be more supportive and dialysis. So just sort of a broad comparison between tubulointerstitial diseases and glomerulonephritis. So this is just kind of recapping what we just talked about. So there's a lot of glomerulonephritic diseases, and the best way to think about it is, one, is this patient having systemic symptoms? Is it just limited to the kidneys? Are they just having urinary symptoms? Is it just they're just losing protein, red blood cells in the urine, hematuria, renal symptoms? Or are they having symptoms in other organ systems? So is it systemic or is it renal only? And then after you distinguish whether it's systemic or renal only, then it's usually good in any renal workup to have a complement level. And so do they have a normal complement level or do they have a low complement level? And the complement we generally check for is C3. So I've divided it up into systemic with normal complement, systemic with low complement, renal only with normal complement, and renal only with low complement. So first we're going to talk about the systemic diseases with normal complement. And as you can see, this is the largest category. And the first one we're going to talk about is Wegener's granulomatosis. This is somewhat rare in the clinical setting, but it's very common on the USMLE. And what this is it's characterized by a multisystemic vascular disease process where you're going to see prominent renal, respiratory, and skin symptoms. So a lot of times what the USMLE likes to throw at you is a patient that's had repeated respiratory tract infections that did not improve with antibiotics. And what you see with Wegener's is you see a progressive renal failure. You'll probably see azotemia when the patient presents, but as the patient goes on with their Wegener's, you're going to see the patient progress towards end-stage renal failure. So renal symptoms can be common on presentation, but it's not necessary. Sometimes you'll just see a patient with respiratory symptoms. But what you always will see on the USMLE is that azotemia. You will see those labs that are off. So they'll have an elevated creatinine, or they'll have renal symptoms in as much as they'll have microhematuria. So they may not have outward symptoms of renal disease, but you'll see it in their labs. So you'll see the hematuria or the elevated creatinine. What you want to look for in Wegener's when you see the labs is these patients have chronic disease. As you can imagine, when you have renal and respiratory and skin involvement, GI involvement, etc., as a chronic disease, it's chronic inflammation. So these patients are going to have the anemia of chronic disease, which is a normocytic anemia. When you suspect Wegener's, when you have all of this systemic involvement, and you have renal symptoms, and you have this particular skin lesions that I'm going to show you a picture of in a little bit, the best test to get to screen patients for Wegener's is the C-ANCA. And all that is an antibody. So you get the C-ANCA exam, and if that comes back positive, then you can presume they have Wegener's. But in order to establish the diagnosis, you're going to need a renal biopsy. So the best initial test is to see ANCA, but for definitive diagnosis, you need renal biopsy. And on that renal biopsy, you'll see granulomas, which makes sense because this is called granulomatosis. And these patients are treated with cyclophosphamide, which is an immunosuppressant, and steroids. And these are those skin lesions that you see with Wegener's. Okay, so Churg-Strauss Syndrome is basically Wegener's with asthma. So these patients have very, very similar symptoms to Wegener's in that they're multisystemic, but these patients also have significant allergic and asthmatic features. These patients have to have asthma. 100% of Churg-Strauss patients have asthma, at least as far as the USMLE is concerned. So they'll have asthma, they'll have atopic allergies, and so forth. And they'll also have all the things we talked about with Wegener's. So these patients will also have basic labs that show a picture of chronic disease, which is our elevated ESR, elevated C-reactive protein. They're going to have a normocytic anemia, which is characteristic of the anemia of chronic disease. And these patients will also, if you get a CBC with differential, they're going to have eosinophilia. So the best initial test if you're suspecting Churg-Strauss syndrome, so a patient with asthma that seems to have Wegener's, is to get a P-ANCA. So this is different from Wegener's where we get a C-ANCA. So P-ANCA is different. P-ANCA is Churg-Strauss, C-ANCA is Wegener's. And if the P-ANCA comes back positive, then you have a presumptive diagnosis of Churg-Strauss syndrome. And in order to establish the diagnosis here, you're also going to need to get a renal biopsy. You can also get by with getting a lung biopsy. Both of these are going to show granulomas and eosinophils. The eosinophils are particular to Churg-Strauss syndrome because you have sort of this allergic process going on in addition to the autoimmune process. The treatment is going to be generally the same. For the USMLE, it's going to be the same: cyclophosphamide and steroids. Goodpasture syndrome has some similar aspects, but it's a different process. So Goodpasture syndrome is just simply isolated renal and lung involvement. You're not going to have any skin issues. You're not going to have GI issues. You're not going to have anything other than renal involvement and lung involvement. And the way this usually presents on the USMLE is that you have a patient with hemoptysis or blood-streaked sputum, and they also have microhematuria or brown urine. And so usually the pulmonary symptoms present first if they don't present at the same time. So what you'll often have is a patient with frequent cough, sputum streaked with blood, or actual hemoptysis. And then when you have the patient come in, you'll get a total workup, and on the USMLE they'll tell you this patient has a urinalysis which shows microhematuria. And so when you have a patient that's got hemoptysis and microhematuria, Goodpasture should be at the front of your mind. And your first step for diagnosing Goodpastures is to get your anti-GBM levels. And what GBM is, it's the glomerular basement membrane, and that is a membrane, I think it belongs to the type 4 collagen, and that's specific to the lung and the kidneys. So you can imagine that if you have an antibody to that it's going to be specific to the lung and the kidneys. And so it causes the destruction of the tissue, and that's what causes the hemoptysis in the lungs and the hematuria in the kidneys. If those anti-GBM comes back positive, then you need to get either a renal biopsy or a lung biopsy, and you will put this under immunofluorescence for specifically the anti-GBM antibody, and that will come back positive, and that will be your diagnosis for Goodpasture syndrome. So to screen, you get the anti-GBM titers. For definitive diagnosis, you have to get the biopsy. And treating Goodpasture syndrome, we like to use plasmapheresis, and that's just simply because the antibody is directly attacking the tissue, which is causing the hemoptysis and the hematuria. So plasmapheresis plays a good role in Goodpasture syndrome, and cyclophosphamide and steroids are also useful. Polyarteritis nodosa is similar to the previous three, the first two, in that it is a vessel disease, but polyarteritis nodosa is, what you're going to see here is, usually on the USMLE, it's going to be in a patient with hepatitis B, and they're presenting with multisystemic disease, but they're also going to have this really terrible postprandial abdominal pain. So after they eat, they get really bad pain in their abdomen. And what's specific to this is that, one, it's going to be a younger patient. So what do you usually think when you think of postprandial abdominal pain? You think possibly a infarction in the mesenteric vessels. But that's not the case here. These are going to be younger patients. They have Hep B, and they've got postprandial abdominal pain. They may also have fatigue and weight loss. When they come in for diagnosis, when they have these symptoms, you're going to want to have your UA. A lot of times on the USMLE that will be given to you. It'll show microhematuria. Their metabolic profile will show azotemia. And their CBC will show signs of anemia of chronic disease. They'll show inflammatory markers like CRP and ESR. The definitive diagnosis, though, for polyarteritis nodosa is a biopsy, but we're not actually getting the renal biopsy here. We're going to get a sural nerve biopsy, but that's not necessarily needed. If a patient comes in and they have this postprandial abdominal pain, they have hepatitis, and they have anemia of chronic disease and microhematuria, that's enough to suspect polyarteritis nodosa. So know sort of the constellation of symptoms that come with polyarteritis nodosa, know the association with hepatitis B, and usually we're just going to make a clinical diagnosis here. But if you do need to make a definitive diagnosis, it's going to usually be with a biopsy of the sural nerve. Another thing that's good to know is that because this is a small vessel disease, you may see microaneurysms of the capillaries and livido reticularis, which is sort of that modeling of the skin. The treatment for polyarteritis nodosa is going to be cyclophosphamide and steroids. So thrombotic thrombocytopenic purpura and hemolytic uremic syndrome, these are actually two separate disease processes, but they're characterized by the same triad, and that triad is hemolytic anemia, thrombocytopenia, and low platelets. Actually, that's the same thing. What I should say is uremia. So hemolytic anemia, uremia, and low platelets. Sorry about that. I always seem to make a mistake on all these. Okay, so hemolytic anemia, uremia, and low platelets. Patients with TTP are also going to have fever and neuro problems, so they'll actually have a pentad. They'll have hemolytic anemia, uremia, low platelets, a fever, and certain neurologic problems, which tend to be altered mental status, delirium, or hallucinations. So you're going to want to look for TTP, particularly in patients with HIV or with cancer. And you're going to want to look for HUS, particularly in children that have had a recent history of enteritis. And the bacteria that's associated with HUS is the E. coli 0157H7. So the symptoms are as described above. So definitely keep this triad in mind, the hemolytic anemia, uremia, and low platelets. And then keep in mind the extra two symptoms you see in TTP, which is the fever and neurologic problems. This will usually be confirmed with your labs. So your CBC will show low platelets and anemia. And if you get a smear, which if you're really acute and you're thinking about TTP or HUS before you get your labs, you get this smear and you'll definitely see the schistocytes. And all those is your little red blood cells that have got little fragments knocked off of them because being that this is a vascular disease, what you have here are these platelet chunks, and the red cells, as they go by these platelet chunks, they get little pieces of them knocked off, so you see these schistocytes. Your urinalysis will show microhematuria in both of these disease processes. The diagnosis is going to be based on your labs, and the treatment is going to be supportive. What's more important for the USMLE is that you know what not to do. And what not to do is to give antibiotics or platelets. So you might think, okay, well, this patient, this child has hemolytic uremic syndrome, and he just came off of having enteritis with E. coli. Maybe I should give him antibiotics. That's absolutely the worst thing to do. So you never give these patients antibiotics, and you absolutely never give them platelets. And that's even more sort of anti-intuitive, because you think, all right, well, these patients have low platelets, I should give them platelets because they're bleeding. Don't do that either, because what the main disease process here is it's platelets sticking together and lodging on to the blood vessels. And what happens here is we have uremia and we have hemolytic anemia because the blood is passing by these platelet chunks and it's destroying the blood. So we don't want to give platelets. That's going to worsen the disease. If we have really bad bleeding, what we can do is plasmapheresis or fresh frozen plasma if there's significant bleeding. But for the most part, when we have patients with TTP and hemolytic uremic syndrome, we're going to primarily just do supportive therapy. We're going to admit them to the ICU and monitor them. Diabetic nephropathy. These patients are going to be those with long-standing diabetes, uncontrolled diabetes, and hypertension. And they have, on labs, they have microhematuria or proteinuria on a routine urinalysis. So patients with diabetes, they're advised to have routine urinalysis and other various labs. These patients will usually have hypertension on the question stem, and diabetic nephropathy is just simply part of the natural disease process of the diabetes, especially if it's poorly controlled. So diagnosing diabetic nephropathy is pretty easy, and it's kind of a diagnosis of exclusion. What we're going to see in the question stem is a patient that has diabetes that got a urinalysis, and they have a 2+ red blood cells in their urine and 2+ protein in their urine. And they also happen to have A1C of 8%. And so they have poorly controlled diabetes, and they've got symptoms of renal disease. And there's really nothing we can do for these patients for their renal disease. We just have to treat their diabetes. Make sure that they're controlling their diabetes with strict glycemic diet control, and make sure that we're treating the patient's hypertension, because hypertension will cause worsening of the nephropathy. So we control these patients' hypertension with ACE inhibitors, which are renally protective, or angiotensin receptor blockers. And of course, these patients should be in routinely for A1C checks. Membranous glomerulonephritis is the most common cause of nephrotic syndrome among U.S. adults, and it is generally idiopathic. So when you have an adult come in with blunt symptoms of nephrotic syndrome, so they have the edema, they have hyperlipidemia, they've got their legs are puffy, their face is puffy, you're going to want to think, okay, this is nephrotic syndrome. And if they don't have a pre-existing renal disease, if they don't have hepatitis, and they don't have lupus, and they don't have anything that's going to make you think TTP, this is what you're going to want to think. This is going to be your default when an otherwise healthy adult comes in with nephrotic syndrome symptoms. So membranous glomerulonephritis is the most common cause of nephrotic syndrome in U.S. adults. And as you can imagine, since they have this puffy edema, their urinalysis will show 4+ protein. The patient will likely have hypertension. hypercholesterolemia, and when you get your 24-hour urine protein, it'll be in clear excess of 3.5 grams per day. So these patients have full-blown nephrotic syndrome, and membranous glomerulonephritis is going to be your answer, unless there's anything else which may make you think of another diagnosis. Then you're going to want to exclude those. So healthy patients with nephrotic syndrome, with puffiness, urinalysis 4+ protein, hypertension, hypercholesterolemia, more than 3.5 grams a day, membranous glomerulonephritis. The treatment here is going to be symptomatic. We will treat their proteinuria and hypertension with ACE inhibitors or angiotensin receptor blockers. We can add diuretics to drain their edema, and then just keep them on a low salt diet while they're dealing with this. And this will eventually clear up. Now, if the patient is an adult, membranous glomerulonephritis is well and good. But if the patient is a child, what should be at the front of your mind should be minimal change disease. We'll talk about that later. Amyloidosis is characterized by progressive renal failure as well as other systemic problems in a patient with another systemic malignant or inflammatory condition, particularly multiple myeloma. So these patients have something else. They've got breast cancer, they've got multiple myeloma, they've got inflammatory bowel disease like Crohn's disease or ulcerative colitis. They've got something else that's a lot bigger of a deal. And then unfortunately they come in and they've got something else now. They've got renal problems. And so what you have here is because of the inflammation or because of the malignant cells, they're creating amyloid protein, and that amyloid protein deposits in various tissues, and that's what's actually causing the different symptoms. So all these patients will have another significant medical condition, and what you see in amyloidosis, curiously, is this enlarging of the tongue, which I'm not really sure why that happens. I'm not sure if any of us know why that happens. And you'll also see malabsorption a lot of times because the amyloid protein deposits in the intestine. Your labs will show azotemia. Of course, you're going to see anemia of chronic disease, and that's not necessarily because of the amyloidosis, but it's because they have some kind of inflammatory condition or malignant condition that coexists. And they will have an elevated ESR or CRP. So amyloidosis, the way we diagnose this is with renal biopsy. But what we have to do here is we have to get a special stain, and that's called a Congo red stain. And you probably remember this from USMLE Step 1. That Congo red stain with amyloidosis will have the apple green birefringence. And most of the time on the USMLE Step 2 or 3, they'll just throw a similar question at you. They'll say that this patient has renal symptoms, they've also got multiple myeloma, or they also have Crohn's disease, and now they've got this renal failure. You get a renal biopsy and you see apple green birefringence. What is it? And it's amyloidosis. And the way we treat this is by treating the underlying disease process. There's really nothing else we can do other than treating the inflammation. Alport syndrome is rare. USMLE likes to test it, but luckily it's pretty distinct, and it tends to be X-linked dominant, and it's characterized by deafness and renal abnormalities. And sometimes you'll see visual problems too. So the deafness and visual deficits, this tends to be a disease of pediatrics, and that's simply because when does deafness present? It presents when you're a child. So for test purposes, this will usually be a young child who's deaf, and when they come in, they have an abnormal urinalysis which shows microhematuria. Your diagnosis will be Alport syndrome. There's no therapy here. You just educate the patient and the parents about the possibility of nephrotic syndrome developing in the future. Of course, they're going to want to be consulting with a nephrologist. So, moving on to the systemic glomerulonephritic diseases that have low complement, and there's just 2 of them. So cryoglobulinemia is a systemic disease that's associated with hepatitis. You can probably see a pattern here. You might want to make note of the diseases that are associated with hepatitis. And this is a systemic disease that is associated with progressive renal symptoms, but also has joint pain and those purpuric papules that we see in some of the other diseases that we'll talk about in a little bit. We haven't gotten to it yet. And characteristic low levels of complement. So the main differential is the Henoch-Schönlein Purpura, and that's where you also see those purpuric papules with renal symptoms. But in cryoglobulinemia, what's different is, one, this tends to happen more in adults. Two, it tends to happen more in patients with hepatitis. And three, you're not going to see joint pain and low levels of complement in Henoch-Schönlein Purpura. That's the main differential. The symptoms are as above, that are here bold-faced, and the urinalysis will show a nephritic picture, so you'll see red cells in the urine. The diagnosis here is you don't really need to get the complement. The question might tell you have low complement. You should really just go to, when you are suspecting cryoglobulinemia, is just get your serum cryoglobulins, and that'll be diagnostic. If they're positive, it's diagnostic. If they're negative, you rule out cryoglobulinemia. So that's where we go to make this diagnosis. And the treatment here is to manage the underlying cause. Like I said, it's got a high correlation with hepatitis. So you'll treat the hepatitis, and what you use is ribavirin and interferon alpha. You can consider steroids or plasmapheresis if the symptoms are particularly severe. But usually when the USMLE throws this question at you, they're going to want you to differentiate it from Henoch-Schönlein Purpura. Lupus nephritis is a particular manifestation of systemic lupus erythematosus, and that's a multisystemic disorder characterized by a malar rash, fever, joint pain, and particularly in women of childbearing age. So the USMLE will give you a question, and it will give you a vignette that makes it clear that this woman has systemic lupus erythematosus. And then lupus nephritis is a flare-up of the SLE, and it's characterized by declined renal failure and an abnormal UA. Now, what you're going to see on the USMLE is an increased incidence in black women, and that's very true. There is a higher incidence of lupus both in African Americans and in women. Of course, the USMLE takes this to extremes, and they obsess about this correlation, and pretty much almost always when you get a question about lupus, it's going to be in a black female of childbearing age. And another one that is in black females of childbearing age or even older is sarcoidosis. So they tend to obsess about this correlation. Always good to know about these sort of stereotypes that they like to use. Clinically, you're going to see lupus a lot more in white patients in the U.S., and that's simply because there are 9 times more white people than black people in the U.S. But when looking at it in a population, you will see this particularly in black women. So the symptoms and this is the symptoms of SLE, of lupus erythematosus, is the malar rash, arthralgias, fatigue, oral ulcers, easy bleeding, and a pleural rub. So if it doesn't tell you that the patient already has systemic lupus erythematosus, then you're going to want to diagnose that. Of course, if it already tells you that the patient has lupus and then they tell you abnormal UA, this is where you go, lupus nephritis, pretty much always the case. But if they don't tell you the patient has SLE and they just give you these symptoms, then you're going to want to make the diagnosis of lupus. And so what you need to do to diagnose lupus is to get an ANA and then to get either an anti-dsDNA or an anti-Smith. And the reason you need to get both is because your ANA is going to be sensitive. So if the ANA is negative, you can pretty much rule out lupus. And so once you have that positive ANA and you look at your anti-dsDNA or your anti-Smith, these are specific. So they might be negative, and that doesn't necessarily rule out lupus, but if they're positive, it's always lupus. So anti-dsDNA, which is double-stranded DNA, or anti-Smith to establish diagnosis. And your urinalysis may or may not show proteinuria or hematuria. If the patient has an abnormal urinalysis or elevated creatinine on your CMP, and you have an established diagnosis of lupus, then they need to get a renal biopsy. And the reason they need to get a renal biopsy is because flares of nephritis are common in lupus, and this is going to direct our treatment. So an abnormal urinalysis or elevated creatinine plus an established diagnosis of lupus equals necessary renal biopsy. And when we get that biopsy back, it will either be normal, which would be unusual for lupus, or it will show sclerosis, in which case we don't need any treatment at this time, or it will show proliferative nephritis. And if it shows proliferative nephritis, we need to start steroids and another immunosuppressant called mycophenolate. And this is superior to cyclophosphamide. So on the USMLE, if it gives you only one or the other, then choose either mycophenolate or cyclophosphamide. But if it gives you as answer choices both mycophenolate and cyclophosphamide, definitely go with mycophenolate because it has been shown to be superior to cyclophosphamide in treating lupus nephritis. This is that Malar Rash in lupus, and this is actually the this rash is where we get the name lupus, which comes from the Latin for wolf. So now we're going to talk about the glomerulonephritides that are limited to the kidneys, and the first four we'll talk about are the ones with normal complement. So IgA nephropathy, or otherwise known as Berger's disease, is characterized by a mild to gross hematuria, and this is what's most important, commonly immediately following an upper respiratory tract infection. So this isn't your post-streptococcal glomerulonephritis, where it comes like 3 to 4 weeks afterwards. This is like a day or two after you had your upper respiratory tract infection. So look for the time frame when you want to differentiate IgA nephropathy from post-streptococcal or post-infectious glomerulonephritis. It's going to be the time frame that helps you do this. And the reason that we need to differentiate this is because of the prognosis. Half of patients with Berger's disease or IgA nephropathy are actually going to go on to develop end-stage renal disease, unfortunately. And so the symptoms is going to be a mild to gross hematuria and urinalysis. They may be hypertensive, but otherwise these patients are going to appear normal. And so the history is going to be very important, that they just came off an infection or they just came off of feeling ill 1 to 2 days ago. And so we have to keep a high index of suspicion if we have these cases where we have a recent infection and mild to gross hematuria and urinalysis, because the prognosis can be so bleak for these patients. So anytime we even consider that Berger's disease is a possibility, we're going to need to get a renal biopsy to confirm the diagnosis. And so as far as managing the symptoms, we're just going to manage it with ACE inhibitors and angiotensin receptor blockers, and we monitor these patients usually in the hospital. Around half of the patients will remit, and about half will progress to end-stage renal disease. Henoch-Schönlein Purpura, which we alluded to earlier, is characterized by multiple red-violet palpable purpura, as well as prominent abdominal pain and fever. So what's important here is that you're going to have this very characteristic rash, and it doesn't look at all like chickenpox. And these are very common in pediatrics. You can see it in adults, but it's more common in pediatrics. And you're also going to have this prominent abdominal pain. You'll have a prodrome of fever, headache, and nausea, which is very nonspecific. but it's going to be followed by this very, very, very stereotypic rash accompanied by abdominal pain. And when it happens in a child, it's practically diagnostic of Henoch-Schönlein Purpura. And so you'll see on urinalysis microhematuria, and that will pretty much seal the diagnosis. You'll see red blood cell casts, sometimes protein. But once you pretty much can diagnose it based on the symptoms, but you're going to want to get a urinalysis to seal your diagnosis. The treatment is going to be supportive. This always resolves. And this is that characteristic rash that you see. It's a little bigger on this kid than on these, but you can see here this definitely does not look like chickenpox, and you can see that it kind of spares the flexor areas, and you've got these sort of plaques, and they're palpable. They're three-dimensional. They're not just inside the skin. These are plaques. They're purpura. So just keep an eye out for this rash, because a lot of times when the USMLE gives you Henoch-Schönlein Purpura, they'll show you this. All right, so this is a disease most of the time with pediatrics. So keep an eye out for the pediatric patient coming in with these purpura and hematuria. Minimal change disease. So this is the kid that comes in, has been healthy, and now has edema and a puffy face and is tired. So this is analogous to what we had in the adult, which if you go back, you would see, let's see if we can go back here. So in the adult, this is membranous glomerulonephritis. You saw an adult with nephrotic features. In the child, you got the same thing, but we're going to think minimal change disease. And the way we establish this diagnosis is first we're going to want to get a 24-hour urine protein on these patients. So once they have that abnormal urinalysis and the edema, then we got to get a 24-hour urine protein to diagnose any kind of nephrotic syndrome, because we don't get a nephrotic syndrome diagnosis on a simple urinalysis. And then nephrotic range proteinuria in children. I don't suspect you're going to be asked this on step 2, but it may be a step 3 question. I didn't see it on either, but for children, for proteinuria, or for nephrotic range proteinuria, it's not just simply 3.5 grams per day. It's 40 milligrams per hour per meter squared. So it might be good to know that. When suspecting minimal change disease, we have to get a renal biopsy, but not only are we going to send this off for light microscopy, but most importantly, we need to get this sent off for electron microscopy, because, like its name, minimal change disease, you're not going to see hardly any difference. You're actually not going to see any difference on light microscopy. The only difference you're going to see is on electron microscopy, and what it is the fusion of foot processes. Good to know it's fusion of foot processes, but you're not going to be given any kind of pathologic picture on step 2 or step 3. Treatment here is steroids. This is particularly responsive to steroids, especially prednisone, and these kids will resolve pretty quickly. Idiopathic, rapidly progressive glomerulonephritis can be any of the glomerulonephritides if they start to progress particularly rapidly, or it can be a glomerulonephritis that doesn't fit into any of the categories, that is progressing rapidly and we have no idea why it's happening. So what you will see in the idiopathic, rapidly progressive glomerulonephritis on renal biopsy is a quick onset of symptoms, and then when you get your renal biopsy, you will see crescent formation, and the patient will be ANCA negative. So really, this is just a diagnosis of exclusion. We have to get ANCA to check for Wegener's or for Churg-Strauss, but this is primarily a diagnosis of exclusion. It's a rapid onset, rapidly progressing, and the renal biopsy will show crescent formation. And you'll pretty much be told all of that. Most of the diagnoses of exclusion, you're not going to have to order up all the labs, unless, except for maybe on step 3 in the what did they call those? The new tests that they got with the where you have to actually order all the labs. But for step 2, as far as you're concerned for that, this is just a diagnosis of exclusion. They'll tell you all this stuff was negative. You got this patient that's got rapid renal deterioration and a quick onset. And then you get the renal biopsy and it shows quote-unquote crescent formation. Don't even know what that looks like, just know the name. Treatment here is steroids and cyclophosphamide, but these patients will quickly progress to end-stage renal disease. So the final 3, we're getting there, is renal restricted to the kidneys and has low complement. So post-streptococcal glomerulonephritis is characterized by gross hematuria, which is Coca-Cola colored or tea colored, and that's what causes the patient to come in. And then when you quiz the patient on anytime they come in with Coca-Cola colored urine, you're going to want to ask them, have you had a upper respiratory tract infection? You probably won't phrase it that way. You'll say, have you had a sore throat lately? Have you had a cough lately? And if they say yes, and it was a few weeks ago, then this is going to be what you think of. So here they've got this brown-colored urine. They had a recent strep infection, post-streptococcal glomerulonephritis until proven otherwise. These patients may have some edema, but they're generally going to come in because of the dark urine. And like I said, history is very important in the clinical setting. On your USMLE, you're going to be told that this patient had some kind of respiratory tract infection. Your best initial test, your screening test, is going to be your anti-streptolysin O titer. And you can also get your complement levels, which will be low. You're not going to need renal biopsy here. If your ASO is positive, and along with your history and symptoms, that's diagnostic for post-streptococcal glomerulonephritis. And the treatment here is going to simply be supportive, and we're going to want to give them amoxicillin or azithromycin if they're allergic to penicillin to get rid of any of the remaining strep pyogenes organisms from the pharynx. Membranoproliferative glomerulonephritis. This is common in patients with hepatitis, but it's certainly not necessary, and it tends to be a higher incidence in whites. So membranoproliferative glomerulonephritis, besides being 40 syllables long, can be spontaneous or it can be secondary. And the 3 things that it's usually secondary to is hepatitis, systemic lupus erythematosus, or cryoglobulinemia. And so the patient will usually present with edema and hypertension on exam. These patients will tend to be, frankly, nephrotic. And so your urinalysis will show microhematuria, usually 4+ proteinuria. And so you should get, apart from a 24-hour urine protein, you should get complement levels on these patients, which will be low. And your complement levels, when they're low, will help you diagnose the membranoproliferative glomerulonephritis. The treatment here is going to be dipyridamole and aspirin. And then you're going to want to also check the patient for any secondary causes, so hepatitis, SLE, and cryoglobulinemia, just because they're so common, they so commonly cause this problem. And so you can get a Hep B and C panel, ANA, and cryoglobulins. And if obviously whatever underlying cause they have, if that's associated with this, we're going to want to treat that too. And then we move to Focal-Segmental Glomerulosclerosis. So this is characterized by nephrotic symptoms in a patient with HIV. USMLE likes to make these stereotypes. HIV in a clinical setting is not necessary for focal-segmental glomerulosclerosis, but it is highly associated with HIV. This, unlike the previous one, can occur in pediatrics, but commonly the USMLE will give this to you as a black man with HIV or a black man with a history of intravenous drug use. Focal-Segmental Glomerulosclerosis is about 8 times more common in African Americans than in whites. So look for a African American to appear on your question. This can be spontaneous or secondary, just like the Membranoproliferative, and the symptoms are usually going to be nephrotic, so edema and hypertension on exam. This one stands apart from all the other ones we've talked about in that on the urinalysis, you're not going to see red blood cells. I don't know why that happens, but what you will see is significant proteinuria and these broad waxy casts, which are just basically protein turned into casts. So proteinuria, broad waxy casts. What we want to do to treat these patients is to treat the proteinuria and the hypertension, and that will be ACE inhibitors or angiotensin receptor blockers. If they have really significant edema, we can have them pee that off with diuretics. And definitely we want to check these patients for secondary causes, so we can screen for HIV with an ELISA and also check CD4 while we're at it, and then screen for SLE with an anti-nuclear antibody. And so here's your overview. You're probably sick of listening to me, so I'll just kind of cycle through these. So you can copy these slides if you want. And definitely something that you'll want to have a nice overview of, because there's so many different causes of nephritis. And that is it.